The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you so much for joining us today for our live chat. Our topic is caring for someone with Lewy Body Dementia. I'm Lakelyn Hogan, gerontologist and caregiver advocate with Home Instead Senior Care. So again, just want to thank you so much for taking time out of your busy schedules to be with us today to talk about a very important topic. Our live chats are brought to you by Home Instead Senior Care, a network of locally owned franchise offices. Home Instead Senior Care's network offers home care with an individualized approach to keeping your loved one safe and independent at home. And to learn more, you can visit the website homeinstead.com. And before we dive right into all the questions and good information in today's live chat, I do want to go over a few housekeeping items. So first, I want you to know that your lines are completely muted, so we cannot hear what's going on your side of things. If you need to do some laundry, answer the doorbell, type on your computer, if you're driving, we can't hear the cars honking or the dog barking. We're good to go, so we'll keep those muted throughout. And then also, we want your questions. That's the whole point of this live chat, is that we can take live questions from our audience. So as you're listening and you're thinking of questions, please chat them into us. There's a questions box on the right-hand side of your control panel on your screen. So please type in those questions. We'd love to hear from you. We did get some good questions in from our Facebook page, and so we do have a few questions we can get started with while you're thinking of your good questions to ask. And there's no such thing as a silly question. It's very likely someone else out there has a similar question, and the information shared as a result will be beneficial to all the listeners. So again, please submit your questions when they come to you. And then finally, you don't have to take notes. We're recording today's webinar. We will send it back out via email to those that have registered. We'll also post it on our website. So if you really like the content, or you think, wow, my sister, aunt, cousin, friend would benefit from listening, you can certainly send it on to them. So that is all the housekeeping items that we have for today. So I want to introduce our topic a little further. So today, we're going to discuss one specific type of dementia, and that's Lewy Body Dementia. And sometimes it's abbreviated LBD, so you'll hear that acronym probably a lot throughout today's webinar. But LBD are the second most common form of degenerative dementias after Alzheimer's disease. I know a lot of times we talk about Alzheimer's in these live chats, so we're going to narrow it down a little bit more to the second most common form of dementia. And many caregivers that are engaged in our chats and our Facebook community are caring for someone with LBD. And they talk to us about how they have different challenges than caregivers that are caring for other types of dementias. And that's why we decided to find an expert on this topic. So we're going to be talking about LBD, what the symptoms are, some care techniques, and so much more. And we're very fortunate to have with us today an expert on the topic, Angela Taylor. She is the Director of Programs for the Lewy Body Dementia Association. She oversees the association's educational programming and is the lead on all of the association's advocacy and research initiatives. She's a nationally recognized LBD advocate, and she serves on the Federal Advisory Council on Alzheimer's Research, Care, and Services. Prior to joining the staff at the association, she was a family caregiver for her father, who had LBD, and served as president of the association's board of directors. And she's also the association's liaison with their Scientific Advisory Council, and she's been doing that since 2004. So, Angela, thank you so much for joining us today. You have extensive professional and personal background in this topic, so thank you again for being with us. We are so excited to have you.
Thanks, Lakelyn. I'm really excited to be here, too.
Well, I thought if you wouldn't mind kind of just level setting, helping us all get up to speed on what Lewy Body Dementia is. I think that could be a great place for us to start before we dive into more specific questions. Would you mind sharing a little bit about that?
I'll be happy to. First, I just want to provide everybody with just the simple foundation of even what dementia is, because a lot of people think that it's a particular disease, but it's really not. It's more generic than that. It's like saying you have a cold. You have a cluster of symptoms, but it doesn't tell you what's causing it. So dementia simply means a change in a person's cognitive or thinking skills that interferes with their everyday life. But that can be caused by a number of different things. There's actually upwards of 100 or more types of conditions that can cause dementia. Some of those are treatable. There could be a certain vitamin deficiency or a medical condition like thyroid disease, or even something structural in the brain like a tumor. But there are progressive illnesses, disease processes that cause dementia, and that thinking abilities get worse over time. And when we think about dementia, most of us think about Alzheimer's disease. But as Lakelyn, as you said, Lewy body dementia is the second most common form of progressive dementia after Alzheimer's. But it's the very most misdiagnosed form. People think they haven't heard of it because they haven't heard of it, that it must be a rare disease, but that's not at all true. It approximately affects about 1.4 million Americans and their families. And so it's quite common. It's a disease of older age, much like Alzheimer's is. So most of the people are 50 or older when they first develop signs and symptoms of the disease. So what I thought I'd do is just talk for just a few minutes about what those symptoms are, because when we think about dementia, we think of it just being limited to a person's thinking abilities. But LBD affects a lot more than that. So biologically, this disorder has the same changes in the brain as what is seen after life in a person who had Parkinson's disease. So when we compare those brains, they look very much alike. So it won't be a surprise that people with LBD not only have problems with thinking, but they also have changes over time that affect their movement. So they may have stiff muscles, they may have a shuffling walk, they may change the freedom of movement that they have. They might be very stiff and rigid and slow. And that's called Parkinsonism because it resembles Parkinson's disease. The thinking changes in LBD are different than what we see in Alzheimer's. So Alzheimer's disease is a memory disorder where people have problems remembering things that happened recently and then over time, even things that happened long ago. Well, in LBD, in the early stage, people's memory can be pretty normal, but they have other problems with problem solving. They lose that ability to think through things that require understanding how sequences work. They might have problems with understanding abstract thought or analytical thinking. They certainly have problems with planning, and they may experience even changes in their speech or conversation. They have problems paying attention. They have problems understanding how things relate in three-dimensional space. That's called visual spatial skills. They also have changes from day to day or even hour to hour in how well they think, and that's called fluctuating cognition. So changes in their level of attention and alertness and clarity unpredictably. And that's different from sundowning that's typically seen later in the day in Alzheimer's. So in addition to the thinking and the movement changes, they experience a lot of changes in mood and behavior that are commonly seen in different mental health disorders. And so visual hallucinations are one of the common symptoms of LBD, where people see really vividly in their mind, generally people or animals or insects, small things, generally small children or animals. They also tend to have really significant delusions, and that's different from a hallucination. A delusion is when you think something is true even though there's no fact to support it. And so they might get confused and think that something is happening in their area that really there's no sign of. So they might experience depression or apathy or anxiety, also very common in other forms of dementia. Sleep disorders are common in LBD, and that includes the most common sleep disorder we see in LBD is REM sleep behavior disorder. Now, REM sleep is when we're deep asleep and we go into dream state. But when most of us are dreaming, our bodies are very still. Their bodies are actually, we are paralyzed. We do not move when we dream. But a person with REM sleep behavior disorder actually physically acts out their dreams, and that can injure somebody who's sleeping with them if they're having a frightening nightmare. And so they will hit or shout or kick or fall out of bed, and of course that's a concern because they could really get injured. But they also may have insomnia or other sleep disorders like restless leg syndrome or sleep apnea. And then they also have certain changes in systems in their body that are typically automatically regulated. So we don't have control over our body temperature regulation. That's not a conscious control. That's automated. It's called the autonomic nervous system that controls that. And these people, that system starts to go awry. And so they might have problems with digestion. They might have frequent constipation. They might have problems with their blood pressure, that their blood pressure drops when they're standing, and so they can get dizzy or faint. And so this disorder affects almost everything about a person. And so it's very complex for us as family caregivers to understand, and it's also very complex to treat by a physician.
Wow, that was a great overview. I was feverishly jotting notes. I know I just said we're recording this and I can listen to it again later, but I'm just notating all the differences between, you know, Alzheimer's and Lewy body dementia, and there are some significant ones. So you know, it just helps to remind me that when I'm speaking to caregivers or interacting with them, it's important to understand what their loved one's symptoms are, because it could, like as you said, misdiagnosis is so common for this disease. So as we educate people and professionals, caregivers about the different symptoms, it can be very helpful to those caregivers in helping to get, you know, their loved one to the correct specialist and whatnot. So thank you so much for sharing all of that information. I think it gives all of us a great jumping off point into our questions. So if you're ready, I think we have some questions that I would love to start with. You had talked about some hallucinations, and we've had several people write in about their loved ones. They're asking, you know, is it common for someone to see people who aren't there? Casey in particular had asked, as the disease has progressed, she's become, her loved one has become to have more and more hallucinations and delusions. The delusions are especially difficult to deal with. She says, can you offer any resources or suggestions? So let's start with that question.
Okay. So yes, delusions and hallucinations are very common in LBD. Up to 80% of people will have visual hallucinations in this disease. And sometimes it's even the first symptom that families notice, that their loved one may have some subtle changes in thinking, but then when this visual hallucination occurs and this person is seeing something that nobody else can see, it can, you know, really be frightening to the family, even more so than it might not be a frightening thing that this person is looking at. So they may not be distressed. The family may be more upset because all of a sudden they've had a change in what's normal. And so it's a big indication when you see hallucinations early in cognitive impairment that this is a big red flag that this might be LBD, because this does not happen early in Alzheimer's disease. Hallucinations can happen later in the disease, but when it's one of the very first symptoms, that's very suggestive that you need to get to a neurologist who can really delve into what type of dementia it is. When we talk about how do we deal with this at home, I think the most important advice that I want to share with your listeners is that we have to, as caregivers, listen through our hearts before we listen through our minds. So factually, we hear that what they're telling us isn't factually correct, and it's so easy to respond just to that. But it's far more important that we listen to what they're feeling and we respond to that first, because what they're seeing and experiencing is very real to them. And arguing that it's not real isn't going to change their experience, and you're not going to convince somebody who's having a very vivid hallucination. So what you can do is respond to the emotions that they're expressing. Are they surprised? Are they annoyed? Are they upset? Are they afraid? How do you comfort them in those emotions? Can you enter their reality and do what you can to alleviate their emotional response to their hallucination? You know, if I am saying it's too hot in here, even if nobody else is hot in the room, I still want to be cooled down. So that's my experience. So when we deal with hallucinations and delusions, entering their reality, using what is commonly called a therapeutic lie to help them make sense of what they're experiencing, or, you know, helping them even with a change in location, bringing them, you know, using perhaps a therapeutic lie and then moving them to another room so that they're seeing they have new visual stimulus. Those are some really great ways to respond. Some people experience hallucinations through the TV, so you might want to turn off the TV. They might look in the mirror and not recognize themselves. Visual recognition skills often decline over time. My father was convinced, for example, that across the hall from where he lived was an old man. But it was, it was a young man. But in fact, it was an old woman living across the hall from him. And he was really distressed that this young man had women coming into his room every day. And what it really was the aides coming into her room to help this resident. So we really have to step back and not think about our own experience and what they're expressing factually, but really look at this, as I said, looking through the heart to how can we respond to what they're expressing emotionally.
Angela, I loved that, what you said, listen with your heart before our minds. I think as humans, we're just automatically always fact-checking in our brains, and so that's kind of our automatic default. You know, well, that's not true, or you know, that's not how I see it. But if we think first with our hearts and be compassionate towards what they're experiencing, and I liked how you said also step into their reality to try to help comfort them and those feelings that they're experiencing, because they are very real to them, the person with Lewy body dementia. So if we can think with our heart before our mind, I just loved that phrase. So thank you for those tips, and we hope that to those listening who had those hallucination questions that is helpful advice. So we just had somebody write in, Judith. She wrote, how do you convince other family members who only see the person on one of their good days that LBD is real and is the correct diagnosis? Oh, this has got to be a tough situation, Judith. Our hearts go out to you.
Yes, and it's not that unusual either. So people with LBD, as I said, they have fluctuating cognitive skills that change throughout the day. And one of the things that's pretty common is that when they are in a special occasion, whether it's something as mundane as going to the doctor, but it's not at home doing their everyday life, or it's a visit or a family event, it's really interesting to see how much more energy they use and rise to that special occasion. And cognitively, they are going to perform better. What the families don't see is what happens the next day. When the hubbub has died down, the special visitor has gone away, you're now back home from maybe a trip to go visit somebody, and that person with LBD has used up a lot of their energy and their attention. The next day, they are depleted and exhausted. They may be more confused. They may sleep quite a bit. And so the best advice is that those family members need to spend an extended amount of time around the person with LBD to really understand that this is not something that you may notice in an hour's visit. You might need to spend some time alone with the person with LBD, perhaps stepping in as a temporary caregiver for 24 hours, or coming to stay for a longer visit so that you can see them over a few days as this ebbs and flows. So that's really important. And it's not unusual, like I said, for families at the beginning to go, well, is my dad faking it? Because sometimes he just seems really good. And sometimes he's just terrible. So what's going on? And it makes you question your own, what you see as a caregiver too, early. Am I making this up? Am I making mountains out of molehills?
That's some great advice. Yes, spending that extended amount of time. And also I think, well, I mean, just as we've been talking about, so often people don't understand all the symptoms or the signs of LBD. So would you also say that for Judith and her family, providing them with some sort of education, would that be helpful? I know we have a resources slide that we'll get to a little bit later, but I would think that maybe if maybe they're missing some of the signs because they don't associate that with LBD. Do you ever see that happen in families, Angela?
Absolutely, because as you heard, as I went through that long list of symptoms, when we think about somebody having dementia, we don't think about half of those symptoms. And so in order to help other family members appreciate the complexity of what might be going on, referring them to educational materials or forwarding them something that you can download from our website, for example, is a really good way to help them, when they're ready, learn more about the disease. I think the reality is not everybody's ready at the same time. And so sometimes it's a little bit of denial, sometimes it's fear. And, we just don't want to face that our loved ones are going through such a change. And we look for opportunities to not recognize it. But the more we know about it, the more we're going to be able to connect the dots ourselves.
Yeah, that's a great suggestion. They can even forward the link for this recording if they feel their loved one would benefit from this. Well, thank you, Angela, and Judith, we hope that you find that to be helpful. So we have a few more questions that are rolling in, and someone had asked. When we were talking about hallucinations earlier and how to deal with that, those tips were helpful. But they asked if we could speak a little more to the delusion side of things, because you had mentioned how those two are different. The hallucinations are different than delusions. And from what I gathered from your explanation, an example of a delusion would be, when they believe something is true that's not, like maybe somebody stole their purse or something of that nature. Can you just talk a little bit more about those delusions and some ways that families can react or handle those as well?
Sure. And I'll give a couple of examples as well of what my dad experienced, because I think, everybody's going to have their own unique personal history, personal concerns, and some of that may drive some of the delusions. My father was having a difficult time keeping track of his wallet and his keys, and so he got into this habit of putting them together. And then he started to get concerned that perhaps they might be stolen, and so he started to hide them. And of course, if he couldn't find them, he was convinced they were stolen. That's a very common delusion. Another common delusion, which he did not experience, but I hear from many families that they do, is one that actually has a name. It's called Capgras Syndrome. It's when a person thinks that somebody else in their home has been replaced by an imposter. So John and Mary are married. John has LBD. Mary comes in the room and John goes, "Who are you? And where's my wife? Where's Mary? I want to see Mary. You don't belong here." And Mary, understandably, is likely to get upset if this is the first time that's happened. "John, it's me. Don't you remember me?" But if she can just be calm, and say something simple like, "Oh, you know what? I know where Mary is. I will go get her." Leave the room, come back 2 or 3 minutes later and go, "Hi, John, I heard you were looking for me." It's very possible that John will be then relieved that Mary, his wife, has now come back to see him. So we do see this particular hallucination quite commonly. And often it's not just their loved one who has been replaced. Sometimes it's their actual home. They don't think they're at home. And a simple solution to that would be to go out for a ride, come back home, and see if that's not helpful. And if they don't, if that delusion has passed by then. So that's some of the things that can happen. My father was convinced once that they were tearing down a nearby building, but there was absolutely no construction going on. So what I did was I simply, again, I responded to what his concerns were. And his concerns were, well, if they're tearing down the building next door, is my building next? And so I would talk to him about what's going on, and that I've confirmed that even though there's construction going on next door, that there would be no construction where he lived. And so he could watch the construction process or the destruction process, but know that it wasn't going to be happening and his home was safe. So again, it's very much how we might respond to a hallucination. And again, it's they are not seeing something that is visual. It is really a thought process that has just no fact in reality.
I like how you gave some of those concrete examples. I think that is helpful for at least me, and I'm sure for people listening, on how we can handle those types of delusions. It's still kind of stepping into their reality, and while it might not be their visual reality, it's as you mentioned, their thought process reality. And I would say it's kind of that same approach of listen with your heart before your mind, because you can kind of think, okay, if I were asking that question, what would I want the response to be? And that could be a good way for family members to kind of think about it and maybe try that response. And I would imagine, like with Alzheimer's disease, we talk about how, if one response doesn't work or one attempt doesn't work, you mentioned walk away, come back, try it again. And it could take a few different approaches, a couple different times. Would that be an accurate statement before maybe you're able to relieve that delusion or hallucination?
Certainly, it's possible, and some of those delusions can repeat, especially the Capgras Syndrome one. Really, it is about remaining calm, remaining reassuring, doing what you can to not escalate a situation, because that's not going to help anybody. So I think as caregivers, we have to remember that it is really upon us to be a source of reassurance and not a source of increased distress. And we can do that by accident and by being very well-meaning. Sometimes we've got to learn that lesson the hard way until we figure out a better way. But if we can stay in the moment and not worry about our own worst fears and think more about their worst fears, it's often helpful.
All great advice. Thank you so much, Angela. I think I want to just briefly shift our focus from that kind of the care aspect to the more medical aspect. So Monica wrote in and asked if there are treatments for LBD, and she asked specifically, are there detrimental treatments for a misdiagnosis of LBD? Can you speak
that
a little
is a
bit,
great
I guess, first
question.
Yeah, first maybe to the treatment side of things, and then, if there is a misdiagnosis, how would those treatments impact somebody with LBD?
Okay, great. So LBD, as you heard, has a lot of symptoms. And the good news is there are medications that can help many of those symptoms. So I've heard it referred to as the most treatable dementia. We can't make the dementia go away, but we really can, if we comprehensively look at all the different symptoms, we can make a good quality of life improvement, not just for the person with LBD, but their family as well, and the person who's providing their primary care. So when we look at the 5 areas of the disease, what can we do for thinking? Do we need to do something for movement? Do we need to do something for behavior and mood? And do we need to do something for sleep or the autonomic dysfunction, those automated processes? And the challenge with LBD is that when we treat one thing, we may tip the scales and make something worse, depending upon what we're trying to treat. So the good news is that the medications that are used for dementia in Alzheimer's disease, for the cognitive skills, are also helpful in LBD. In fact, they are typically more helpful in LBD. And so early treatment of that, of the confusion and the change in thinking skills is really important. And the benefit of that is that those medicines may also help some of the hallucinations and the anxiety and things like that. So sometimes you get a 2-for-1 effect, and sometimes you only get benefit in one symptom area. So that's really good. When it comes to the movement symptoms, we want to be really conservative about treating those, because some of the medications that are used in Parkinson's disease are very likely to worsen hallucinations in LBD. So there are a few medications that are less problematic, but doctors tend to be very conservative about treating the motor symptoms. But if it's really affecting a person's ability to function and to be physically more comfortable, then it's worth treating. But if it's only minor stiffness or minor muscle, slow movement and whatnot, then it's okay to not treat it. We're just not, it's not worth taking a risk that we might make something worse. The behavioral symptoms are again, we take the same approach, very conservative. We want to treat the mood symptoms. So if somebody's experiencing depression and anxiety, we can, that can be treated early, and that can really be helpful. The visual hallucinations and the delusions, doctors take a conservative approach, because just like when you treat the Parkinsonism, you might make the hallucinations worse. The same is true in reverse. You treat the hallucinations, there's a chance that the Parkinsonism may get worse. So it's a balancing act. It's what is really significant enough to be treated. If somebody's not having scary hallucinations and you as a family can work around it, then they don't need to be treated. Just because they have a hallucination doesn't mean it needs medical attention. But if it's really distressing, if it's making the person very resistant to care, or it's upsetting them enough that they can't cooperate, then it's important, and you need to talk to the doctor about what can be done to treat it. But again, there are only certain medications that are used in LBD, because people with LBD have a very high level of sensitivity to this type of medication. And there are medications that can be actually even dangerous in treating the behavioral symptoms. And so again, this is where you need expert care. You need a specialist who can carefully navigate through what type of medications to use. And then the autonomic symptoms, things like chronic constipation. Well, those can be easily treated. That's fiber, that's fluids, that's exercise and movement. So not every treatment includes medication. Physical therapy, occupational therapy are really helpful over the course of the disease, and speech therapy too, which can help as the disease progresses, and as the throat muscles may be affected by Parkinsonism, speech therapy can help with swallowing and voice quality and strength. And so there's lots of ways to look at how do we treat, and it makes certain symptoms better. But yes, there are treatment differences. A person with Alzheimer's disease is not going to face many of these symptoms, and so they won't be treated for them. And somebody with Alzheimer's disease is likely to not have the same high degree of medication sensitivity seen in LBD. So if somebody's given an Alzheimer's diagnosis and what they actually have is LBD and they experience hallucinations, a doctor may not be as conservative in treating the hallucinations. And so that can be a real problem. So seeking a differential diagnosis on what type of dementia is going on. If you have some symptoms that you think make this possibly LBD, you really do need to go and pursue that differential diagnosis. Sometimes that requires a second opinion, or a specialty center where you go into a clinic where that's really what they do, is they focus on memory disorders, cognitive disorders. And you can find those often at a teaching hospital. They will often have specialty clinics. And one of the things that LBDA launched this last year, we launched our Research Centers of Excellence program. And on our website, you'll find if you go to our research section, you can find a list of 24 major medical institutions who have LBD experts on staff. And you'll find that information on our website. They are across the country. We launched this to make it easier for families to find LBD expertise. And also, we think it's going to increase opportunities to participate in research as well, because one of the things that's most needed in LBD are better, safer treatments for some of these symptoms, especially where we have those medication sensitivities. So we hope that this is the part, this is one of the ways that we can help move things forward so that we have better treatments for the LBD community.
That was all wonderful information, Angela. And Monica, we hope that answered your question. And we will be sharing the LBD website in just a little bit, so you can visit the site and get all of that great information that Angela just mentioned. I mean, so often when there's a diagnosis, people automatically ask, what are the different types of treatment? So I think having you go over those 5 areas, the thinking, movement, behavioral, mood, sleep, that autonomic dysfunction, that's helpful, I think, for me and for caregivers as they talk to their loved ones, medical professionals about the different treatment options. Can I just ask, we talked about getting an early diagnosis and the importance of that. If families are starting to see some of the signs and symptoms that you mentioned at the start of the hour, what is the best, process to get a diagnosis, or what would you suggest as kind of those first steps in the diagnosis process?
Well, most of us have a primary care physician. That's always a good place to start, because they're going to look for those things that might be might be a treatable cause for some of those symptoms. This disease can have some of these symptoms can be caused by too much of a certain type of medication accumulating in the system, or as I said, treatable medical conditions. So first you want to rule those things out, and that's what your primary care doctor does. And if he's not finding any particular cause for the cognitive changes, he or she should refer a person. If he suspects LBD is one option, that needs to be referred up to a neurologist. We did a survey of the LBD community, and over approximately 2/3 of the diagnoses were made by specialists. So that's geriatricians, psychiatrists, and neurologists. So that's really important. And the neurologist is going to be looking at not just your cognitive function, but they'll do a neurological exam, which looks at things like the way you follow commands, your ability to walk normally, etc. They will do some brain imaging and look and see if there's something like, are there signs of a stroke? Is there anything structurally changed in the brain that might explain your symptoms? They will also possibly refer you to more detailed and extensive cognitive tests. And a doctor, the healthcare professional who provides those is called a neuropsychologist. And that's a battery of cognitive thinking tests that take hours. And that comes back with a very detailed analysis of what areas of our cognitive skills are impaired. And that can really help point to LBD. But certainly a thorough screen for all of the different symptoms that I described is something that's going to most likely be done by a neurologist.
Thank you so much, Angela. I think that is helpful. Sometimes people just don't know where to start. So I think that those were some great tips. Thank you for sharing that. We've had some more kind of symptom-specific questions come in, so I thought I would throw one of those your way. Darla just wrote in. She said, I hope I didn't miss this in the beginning. She tuned in late, but she said, what about body jerking as a symptom? My mom is in a facility, and the nurses say this will only get worse. And at times, she will stare and be unresponsive, have jerking in her arms and hands. Is this part of the disease? So would you have any thoughts or advice or comments for Darla on that question?
Yes. Hi, Darla. Thanks for the question. Yes, so you are right. These can be part and parcel with the disease. Staring off into space specifically is part of the way fluctuating cognition appears. People may just appear to be unresponsive, not taking in their environment and whatnot, and that just, again, that can come unpredictably. So that's one way that we see cognitive fluctuations expressed. Changes in motor skills which can include, as I said, slowness of movement, stiffness, change in walk, perhaps a tremor. It can be people's facial expressions become very slack. That's called masked face, where they really look unexpressive, like their muscles have just kind of gone soft. These are all signs of Parkinsonism. Now, if a person's having twitches or jerks, sudden movements, things like that that are out of control, some of that can be caused by some of the medications that are used to treat Parkinsonism. So it's hard to tell without a doctor really assessing that, whether that's symptom of the disease or whether that's medication, something needs to be adjusted. So that's something for you to explore further.
Thank you, Angela. Darla, we hope that helped provide some more further clarification for you on that question. And we had kind of another symptomatic question come up. Christine wrote in and she said, how quick do the motor skills decline? My dad has lost the ability to walk very quickly in just 6 months. He does not have hallucinations or delusions, so do certain symptoms present before others? So do you have any thoughts on that question that came in from Christine?
Yeah, and that allows me also to explain something really interesting about LBD in general. So Lewy body dementia is kind of an umbrella term. And in this, so there's two diagnoses, two very specific diagnoses that kind of fall under that umbrella. People who have Parkinson's disease and later go on to develop dementia have a form of Lewy body dementia. It's technically called Parkinson's disease dementia. And that's because people with Parkinson's disease have the same Lewy bodies in their brain, as a little misfolded protein deposit, as the people with the other form of Lewy body dementia, which is called dementia with Lewy bodies. And these people, their earliest problems are more on the cognitive side, and then they may later develop Parkinsonism. And so these are kind of like mirror disorders. One might start with cognitive symptoms, the other one starts with motor symptoms, but over time they share pretty much the same array of symptoms as the disease unfolds because they have the same biological process going on in their brains. So when a person has significant changes in their motor function, that might be because they might have started with motor symptoms that progressed over time, and so that's a natural evolution of that. If somebody has lost it earlier in the disease, if they started with cognitive symptoms and very quickly started to have, well, at some point in their disease process had significant changes in their ability to walk, then one has to ask a couple questions. Is this the disease progressing rapidly? Because it is possible a small number of people do have a fairly rapid rate of progression. If it's somebody who's had the disorder for a long time, it may be that they're entering a more advanced stage of the disease. And so, I can't address anybody's unique situation, and I wouldn't want to because I'm not a doctor, but I would say if something has changed suddenly, it's important to have a conversation with the doctor and ask the doctor, is this being caused by anything else? And I will say we see that more often in confusion and behavioral changes, that something as simple as a urinary tract infection or a sinus infection can cause sudden worsening of thinking, sudden worsening of changes in behavior, and that's because their bodies are already fighting something else medically. And if you can treat that, then that improves their symptoms and they go back to their baseline. If it's physical strength and they're losing physical strength, that is often indicative of advanced disease. My father, as he progressed, so my dad lived with his disease for about 7 or 8 years. And that's, the average lifespan of somebody with LBD from the time they're diagnosed and have the symptoms where the doctor can kind of do the math, is 5 to 7 years. And so my dad felt right within that pretty normal time frame. First couple of years, he was physically quite robust. As he got more into the middle stage of the disease, We started to see his walk slow down considerably. It'd be more difficult for him to get around. And as he progressed into the advanced stage, he became much weaker. And we transitioned him so that he would not fall. He moved into a wheelchair. And eventually, towards the end of his life, he really wasn't able to stand up and bear any weight on his legs at all. He could not help transfer from sitting to a bed. So in his case, that was an indication that he was really, his disease process had evolved enough that he was really in the final months of his life. And that was about the time we called in hospice. So it's different for everybody. That's one of the unique things about this disease, is that we have different combinations of symptoms at the beginning. We have different severities. Some people have more hallucinations. Some people have more Parkinsonism. Some people have worse autonomic disorders. So we just can't predict that just because one person's experience has worse symptoms in a certain area, that it's going to match what somebody else's experience is. And so it's a rather unique challenge to compare notes when we're talking with families who have somebody in their family who has LBD, because if we're talking in the short term, their experiences can seem quite different. But when we talk about it over the long term, we find so much similarity in what we've experienced, and we really can be tremendously supportive to each other in that by sharing our experience.
Well, Angela, I think that your personal experience was very helpful in explaining or answering Christine's question. And so I thank you for sharing that, Christine. We hope that helps to answer your question. And we actually did have a couple questions about kind of the final years. Casey had written in, and you've kind of addressed this already, but I want to give you maybe the opportunity to expand upon it a little bit. But she says, I know it varies by person, but what should I look for when my loved one's approaching the final stages, and how should I prepare? And then she also had asked, what are effective ways to prepare for comfort when all else fails? And what ideas do you have about selecting an appropriate hospice program? I would imagine that's a common question families would have, especially since it is, a progressive disease, especially when it comes to those final years. So any thoughts on these questions, Angela?
Sure. So, when there are no formalized stages of LBD, again, it's really hard to predict because people's individual courses are different. So I like to think of it as early, middle, and late stage disease. When I think of late stage disease, I think of the person having a much higher need for care in pretty much all areas. So they're no longer able to perform any of their activities of daily living. They cannot dress themselves. They cannot do all their personal hygiene. They need assistance in a toileting schedule. They are really dependent on somebody to care for them, make sure that they get adequate nutrition, etc. I think there's two things we need to think about preparing, both the caregiver and where we are mentally and emotionally, as well as the practical aspects of care. So I'm going to just limit this answer to the practical aspects of care because I think that's more along the lines of what I heard her asking. Recognizing that this is a disease, we have to prepare and think ahead of what our loved one is going to need as the disease progresses. And I will say that if in our minds we ask ourselves, do we think our loved one could possibly pass away in the coming year? That's a pretty good indication that you might want to start asking your doctor whether he sees the same thing. Are they getting significantly weaker physically? Are they having problems swallowing their food? As I mentioned, there's changes in the muscle tone and the muscle strength, and that affects swallowing. People with LBD, as the disease gets into a more advanced stage, have problems getting food down safely without the risk of aspiration. And so at some point, there may be a change to a mechanical more processed food so that it's smoother and easier to swallow. So when these things are happening, again, that's when we have to ask, what additional services and resources do we need? And I am personally a big fan of bringing hospice in as early as possible because they provide so much more comfort-based support than what we might think to do on our own. And they're very proactive about looking for things as simple as, our loved ones are older. Do they have pain that they're not able to express? And it could be nothing related to LBD. Do they have arthritis? Are they inactive? And is that causing more physical pain than they might be experiencing? And how do we alleviate that? They provide, more assistance with equipment such as a hospital bed. Makes it so much easier to raise and lower and keep the bed in our loved one comfortable in bed, because we can raise the head of the bed if they don't have the physical strength to sit up more easily. So they will bring in things like that, and a wheelchair, special padding, etc. They also help us by providing more care assistance and more frequent medical care with visiting nurses and things like that. So I think when we see our loved ones' physical frailty become quite evident, that is a time for us to be asking those questions. I was the one that brought it up to my dad's doctor before my doctor brought it up to us. And I'm very glad that we did. And I heartily encourage families not to look at this as something that we have to wait till we're sure they're in the dying process. Let's leverage the supportive palliative care services early for better quality of life. And so that we can focus on the things that we can do that also provide comfort. And this is the second part of her question. How do we provide care when they're at an end stage or advanced stage that help address them, make sure that they're as comfortable as possible? And that's where we can turn to things like music or favorite foods, or something as simple as a hand or a foot massage, that our care and the way we express love becomes less interactive and more hands-on, more environmental. What do we do to make their environment, thinking about what they have always loved, something that they can experience just through their senses? So that could be aromatherapy. That could be, something soothing musically in the background. Lots of options for us to consider there. But it's really based on what do we know about our loved one and what will they enjoy. For my dad, it was trumpet music. He was a trumpet player, and nothing made him happier than when I would put on one of his favorite musicians.
Angela, I think that you had such a beautiful answer to that question. I don't think I've ever quite heard hospice explained in quite the way that you did. I think you brought up so many great points, and so often families don't enlist the help of hospice soon enough. Usually they think it's only in the last couple months, days, or weeks or days of life, and it can really be so beneficial, not only for the person with the disease, whether that's LBD or Alzheimer's or any other form of end of life terminal stages, but also they provide support to the family too, which I think some people don't always realize. So thank you for sharing that, and we hope, Casey, that gave you some good information and helps you make those decisions with some more education, more tips on that. So I think before we head to our last couple questions, we'll pull up the resource slide. At least that way you have time to look over some of the resources. Angela's provided us with some great resources from the Lewy Body Dementia Association. As you can see, she mentioned earlier those centers of excellence. There's a booklet, a symptoms checklist, and if you want to get up to date on the state of science surrounding LBD, that website's there. And then as far as the top 3 bullets, those are our community. So if you haven't already plugged into our Help for Alzheimer's Families email list, e-newsletter, we do send out weekly emails. A lot of the content is sourced from caregivers themselves. So it's caregivers supporting other caregivers. We also have a very supportive community Facebook page. It's not it says Remember for Alzheimer's, but we talk to all different types of dementias. And then if you need some extra support or respite, Home Instead's website's there for home care services. But Angela, did I speak to your websites correctly? Anything else you want to add to your resources that are listed up there?
Well, I think the one thing I wanted to highlight is that the family caregivers often are the individuals that we serve first. They come to us with concerns and need for support. Early in this disease, families are quite concerned, and they may already be struggling with the caregiving demand and a shift in roles, etc. The thing that I really encourage families to do is to reach out and find a way to connect with others in the LBD community. So we offer several ways to do that. Certainly, we have local support groups across the country. I think there's over 130 of them run by volunteers and professionals who are really familiar with LBD. We also have a toll-free number to call if you want to get connected to another family caregiver. We help you. We'll act as the liaison to connect you to somebody so you can ask your questions firsthand to somebody who's been there, done that. Our website is full of educational resources. Also, our Facebook page is a really great way for families to stay connected to each other and with LBDA. And our newsletter is certainly something that families will want to subscribe to. It's a free e-newsletter to keep you up to date on what's going on, what new resources we have, what educational events we're doing, and also to hear stories. We highlight stories of other LBD families because we want you to know that you are not alone, that your experiences are quite common, and it's normal to be struggling, and we want to help you find the support that you need.
Thank you for sharing that information. And we have one last question that I also am going to piggyback another question on. So Rhonda just wrote in, and she says that her husband is in the early days, has a recent diagnosis. He's only 62, and lately he's been laying on the sofa watching TV all the time and sleeping. She says, I'm challenged because I'm trying to get him involved in life and keep him engaged. He doesn't seem to be interested. Is it best if I just leave him be or continue to engage him? I'm paraphrasing. She wrote in a lot, which is fine. I just want to make sure we get to it. But I'm wondering, do you have any advice for Rhonda? And also, twofold, are there resources for people living with the disease, when they're first getting the diagnosis, ways to kind of cope, or other people with the diagnosis that are maybe early on that they can connect to? That might be helpful for Rhonda and her husband in this situation. So I'll let you use the last couple minutes maybe to speak to Rhonda's question.
Okay, I'll start with the last one first. We have a private Facebook group for people who have LBD. That's a great way for anybody who's recently been diagnosed to kind of help acclimate and realize that life doesn't end with your diagnosis. Diagnosis frames up your experience and gives you some ability to plan ahead and to adapt, but it doesn't end your life. It is the beginning of a new journey that you have to be creative in to continue to maintain a quality existence. And that's what we want for people with LBD. So when I think about family caregivers who are struggling because their loved one may be experiencing apathy, they've lost desire to do things that they used to do, they might be experiencing depression. These are common symptoms in the disease. One is to talk to the doctor. Can we treat that medically to help them? It's really important. So that's the first step. The second is to remember and think through what mattered to them. What did they really enjoy doing? And finding ways for them to experience that. Perhaps it needs to be adapted for different, declining skill sets. But how do we still get them plugged into those things that are their personal passions? If it's golf and they're not able to golf, as it was with my father. He still liked to go to a putting green and practice putting. He couldn't go out and play 8 rounds, a whole round of golf, but he could do some of it. It would be going to an event. And I know that it's hard to get somebody who's tired up. But again, you personalize it. What is it that has always mattered to them? Those are the things they're going to be more willing to do than the things that we might think they need to do. I think keeping people socially stimulated, physically active, and feeling valued, feeling that they contribute value to society are the things that are going to maintain their wellness, in addition to what we can do for them medically and the emotional support we can give them. So I would encourage you to look to see how you can do that for your loved one.
Thank you so much, Angela. And that really takes us to the end of the hour, but I think that information that you just provided is not only hopefully beneficial for Rhonda, but for all caregivers and for all people who have just been recently diagnosed. We say that similar things about any type of dementia is sometimes people feel that, their life ends with the diagnosis, but that's not the case. We want people to still live a quality life, a fulfilling life, even with a diagnosis. So thank you, Angela, for sharing all of those tips and resources. I've thoroughly enjoyed today's hour, and I know it's been beneficial to our listeners. So thank you again for your time.
It's been my pleasure. Thanks so much for the invitation.
Well, and we're so glad you accepted. And everyone else, we do have another live chat scheduled already for next month. It's at the end of the month, July 31st. It'll be at 1 p.m. We are having Michael Bogan back. Last year, he came on to talk about his diagnosis of Alzheimer's, but there's a twist in this story. He had a misdiagnosis of sorts. So he's going to talk about his diagnosis journey, what's changed in the last year for him, and share, again, his experience with us. He's a passionate advocate still for dementia and for those caring for people living with dementia, so we're excited to have him back. So you can register on helpforalzheimersfamilies.com, and that is the site that this recording will also be posted to in the coming days. So thank you again for tuning in, everyone. We hope you found today to be valuable. If you have any questions, always feel free to email us at livechat@homeinstead.com, and we look forward to talking to you on July 31st. In the meantime, be kind to yourselves. Know that you are doing important work. Your care for your loved one is appreciated not only by them, but we appreciate all that you do for those that you're caring for. So take good care, everyone, and have a great rest of your day. Bye.